Good morning. Is this the first time y'all have been together in 3 years? It's crazy, isn't it? Like actually seeing people, seeing people you thought were taller than they are on Zoom. I always get you're way shorter than I thought you were on Zoom, which I've been used to my whole life. I'm really honored to be here. Thank you, Wes, for that. Thank you, Kate, for this invitation. So I'm just going to jump into stuff. I really have nothing to disclose in terms of conflicts or anything like that. I entitled this talk Because All We Have Is Each Other, which is what I entitle a lot of my talks, because all we really do have is each other. But I wanted to focus this on the intersection of health and education. So I'm going to start with this photo. We all have origin stories. This is my family. My two sisters are adopted. The one on to my, so I'm the kid in the white T-shirt. To my left is my sister Carrie, who we adopted in 1973. She came to us from Korea when she was 3.5 years old. She, in third grade, was diagnosed as having a learning disability and was sent on the short bus to a different school until it was determined after 1.5 years that she had dyslexia. And when she was given accommodations, she was allowed to come back to our elementary school where she thrived. She got a master's degree in special education and actually teaches in the classroom where she attended. It's an incredible success story. And that was really my first interaction with how education and health and development and well-being intersect. I'll just really quickly, everybody else, my sister to my right is Julie. She's a medical social worker. My brother is a pediatric pulmonologist at Seattle Children's, and he is holding Peggy, the epileptic rescue dog, who sadly is no longer with us. We moved from the East Coast to Los Alamos, New Mexico, which you've seen Oppenheimer. It's that place. I spent 3 years working in the plutonium facility when I was in college, which explains a lot about me. If you turn off the lights, I probably glow. Los Alamos was a town of 17,000 when we moved there, and you can imagine when we walk into a restaurant anywhere, we would get a lot of stares. My parents were always asked, "Are you teachers? What's going on here?" And when we moved to town, evidently they felt the need to warn everybody, these folks are here. So as Wes mentioned, one of the roles that I have at OHSU is serving as the director of the Oregon Center for Children and Youth with Special Health Needs. This is the state's Title V public health agency for this population. And in 47 other states, the office that I lead, with an incredibly wonderful team, would be housed at the health department of the health authority. Oregon, in addition to 2 other states, carved that out and installed it at the academic institution. Our focus is really on ensuring that kids with special health needs, which is, when I say that word, I always wonder what people envision in their head. Who are you picturing? What population is that? I tell you, as a practicing pediatrician, I don't know how to get my arms around that population. I know who in my panel that might be, but when you think about it at the population level, especially when you start talking to different communities, the level of the understanding is a little bit weird. We work with local public health agencies. We run the Cocoon public health nurse home visiting program, and we understand how important it is to partner authentically with communities and the places where kids are, which, as you know, is going to include school. Going back to my origin story, this is one of the single most impactful things that ever happened to me as a pediatrician. So as Wes said, when my wife and I finished residency, we went to work with the Indian Health Service on the Navajo Nation, and we ended up in a place called Gallup, New Mexico. If you ever driven west on I-40, you may have driven through Gallup, and it's one of those places you drove through and glad I don't live here. This is where Gallup is. It's about 90 miles south of the Four Corners, right on the New Mexico-Arizona border. The town itself is about 17,000 on a Tuesday. You can see on the right, what I'm trying to show there is that Gallup is surrounded by the Navajo Nation. And then about half an hour to the south is the Zuni Pueblo. So there are two sovereign nations that basically envelop this small community. The reason that I said that Gallup is 17,000 on a Tuesday, because on a Saturday, there are between 70 and 100,000 people in town, because everybody pours in from the res, because that's where Walmart is, that's where the laundromats are, that's where... the county in which we live is about 45,000 people. When we were there, around 45% of the kids lived in poverty. Many families would have to drive 3 hours to see us in the clinic where I worked. Around half of the families that we worked with, and this was between 1996 and 2000, I'm just trying to set the frame here, half of the families we worked with had access to electricity, and only 20% had access to running water. It's better now, but it's still not great. Big infrastructure issues. I had always envisioned a career in international health, spent a month on the reservation, 3 hours from where I grew up, and realized there's a need here. This is where we worked. This is the Gallup Indian Medical Center. It is a hospital built by the federal government in 1961, which looked and acted exactly like a hospital you would expect. Built by the federal government in 1961 would look like. You can see the main entrance there. There were days, a lot of days, we were not allowed to go through the main entrance because the stone facade was falling off of the building, and it literally would take an act of Congress to fix it. So I'm going to take you back to the spring of 1998, and you know how everything looks better in retrospect? So do I. This actually is the emergency department in the Gallup Indian Medical Center. My story doesn't really start here, but this is the picture I have, and I just love using that picture because it's funny. I'm a practicing general pediatrician, and we had a clinic that saw about 50,000 patient visits per year. A lot of kids with special health needs. One of the phenomena that is relatively unique to Indian country is the phenomenon of the founder effect. I don't know how many of you are familiar with the founder effect. The founder effect is basically the results of population bottlenecks. So you take a population, you narrow that population, and then the gene pool gets much smaller, and that can lead to adverse health effects from genetic diseases. I think it was 1861, Kit Carson was charged by the federal government to bring the cavalry to the Navajo Nation and round up the Navajo, which they did. They marched them 325 miles to Fort Sumner, New Mexico, basically put them in a concentration camp, and then 5 years later walked them back. And during that process, well over a third of the population died. And there were communities, especially on the western side of the reservation, where the population was small enough that we saw significant impacts of the founder effect. And there were a lot of things that I saw on Navajo that we just don't see anywhere else. And one of the things that we see is a condition called xeroderma pigmentosa. And that is basically a condition where the skin cannot repair itself from any ultraviolet light damage. And in the most severe cases, it's also associated with a really horrible neurodegenerative trajectory. This is one of my patients, and I'm showing this picture because they were part of a documentary that was called Sun-Kissed that was on PBS. This is a young lady who's about 12 years old and her mother. She was my patient along with her brother. They attended this school, which was about half an hour north of where I practiced. I assumed their care as their primary care doctor maybe when they were 6 and 8 years old. And as I got to know the family, They had we had to send them to the tertiary care center in Albuquerque, which was 150 miles away, pretty frequently. As I got to know the family, there was one day I asked, what are the hardest things that you're dealing with? What do you really want to do? I've only got 5 minutes left. Oh my goodness. Okay, sorry. Long story short, they say the biggest problem we have right now is our kids cannot be subjected to fluorescent light because fluorescent light is UV. And we have to dress them up head to toe and cover every inch of skin for them to go to school, and they can't get out of that when they're in school because the school has fluorescent lights and we've not been able to change that. And so I talked to them about what they needed and what might be helpful. I had just spent 4 years learning to become a pediatrician. I didn't know what an IEP was. I didn't know what a 504 was. And they said, it would be really helpful if you could come to the school and tell them how important this would be. And so I asked my boss, can I go to the school and tell them how important this would be? He said, yeah, that sounds like a good idea. So I was allowed to take a half day off, miss clinic. I went to school, I sat down in the room, and in 5 minutes, the school's like, okay, we'll take care of that. Not because the family hadn't been advocating for it, not because, all of their resources, not because people didn't want to do the right thing. The system just wasn't set up to do the right thing. And I learned then and there how powerful the relationship could be between families and health and education. So I'm going to go really quickly through this. If you Google what is pediatrics, these are pictures that come up. I did this like 2 weeks ago. Sorry, the formatting on this is wonky. This is what I think pediatrics is. This is a quote from a colleague of mine. He said that pediatricians are the ultimate witnesses to failed social policy. Teachers, school health, were all the witnesses to failed health policy. I know that and the American Academy of Pediatrics knows there is no difference between education and health. In the early childhood space, K-12, throughout the life course, education is health. And we know that it's bidirectional, that education leads to better health outcomes, better health leads to better educational outcomes, and that means a better world. This is, I'm just going to skip over this. What I was trying to show here, this is an assessment we did several years ago of the early childhood space in Multnomah County, looking at all of the different pots of money and where they went and the funding streams, and the fact that, number one, there's not enough money, and number two, it's like Ghostbusters, the streams don't cross. We need to fix this. We need to fix this. You know and I know that the health of an individual is only a tiny part of it is their ability to see what I believe to be a high-quality healthcare provider. The rest of it has to do with all of the things that we deal with, where they come from, and we all deal with the ramifications of that every single day. And the fact that we have established a system where healthcare is over here, and the metrics around healthcare are the delivery of healthcare widgets. I guarantee you what my hospital cares about from me is that I'm billing and coding. It's not about health, and it needs to be about health. And if health is education, it needs to be about education. So I don't need to tell you how dire things are for kids, especially in the aftermath of the pandemic. This is a map that was drawn by a family of a child with significant special health needs around all of the systems that go into them surviving a day. And you can see how disparate and complicated it is. And you know that the funding streams and the metrics and the interaction of these systems are all cattywampus and messed up. We need collaboratively to be able to put the child and the family and the community in the middle, bring everybody to the table who needs to be there. You guys, healthcare, support systems, housing, food security, all of those things, and rebuild the system so that we are meeting them where they need us to be, and we're not there. That's what my focus has been. That's the platform on which I ran for the presidency of the American Academy of Pediatrics. We have a council on school health who is incredibly robust and is responsible for publishing a ton of policy. we don't really have a pediatrician school health champion here in this state. It's something that I would love to help find, and I would love your help in figuring that out. How many people here come from communities where you have a relationship with a pediatrician or child health providers, not just providing health care, but helping work towards the health of kids and families in your community? All right, the next time I come here, what I want in my dream is that everybody raises their hand. What we often hear, and what I hear on my end, is we can't afford to do that. We can't afford to send you out to spend time in schools or to work, to be engaged because it's not meeting our needs. I would argue we can't afford not to do that. And this is what I'm hoping we will be able to do collaboratively going forward. Put families in the center and bring all the systems to support them. And if we do our jobs, everything gets integrated, and we have better health outcomes, which is what we all want for everybody. So, indulge me in ending in one story, because sometimes the best things happen outside of your traditional role around relationships and opportunities. And the take-home is always answer the phone call. This is when I was in Albuquerque. As Wes alluded to, I got involved in the world of child advocacy through Child Pastor Safety Car Seats. And I was in clinic at the University of New Mexico, and the phone rings, and somebody answers it, and I say, "Hey, Ben, phone call for you." I said, "All right, hold on one second. Who is it?" I said, "It's the zoo." Hi? So I answered the phone and said, "Hi, it's Ben Hoffman." She said that, and the woman on the other side said, "I heard you're a car seat person." I said, "Yep." And she said, "I need your help." Okay. We have a gorilla whose mom at the Denver Zoo refused to take care of her, and she's being adopted by our zoo, and she's going to be living with me. I'm 3 miles from the zoo. I need to transport her back and forth from my home. So can we put a gorilla in a car seat? This was the coolest car seat consult I've ever done. It turns out gorillas are not little children, in the same way that kids are not little adults. Little children, humans, do not have prehensile toes that can come up and unclip all of the things. Gorillas do. Needless to say, we had to do some things that were not recommended for the general population to be able to do this. This is Tulivu now. She's at the Cincinnati Zoo. She's a mommy. Being able to meet the needs of kids in their community to get them what they need to thrive is why we're all here. I want to make one commitment and one promise to you. Now that you've met me, you can't not have met me. I would be delighted if anybody needs help with connections to folks from the Oregon Pediatric Society, to meet people in your community, to work with the Oregon Center for Children and Youth with Special Health Needs on better collaboration. We are very excited about expanding the work that we're doing in health and education. And as a result of the pandemic, the momentum around health and education at OHA has been stalled a little bit, and I feel like there's now some momentum. The reason I was so excited to be here today was to meet you. And like I said, now that you know me, you can't not know me. Kate has my contact information. Wes knows how to get me. I'm happy to share I didn't bring business cards, but I had an electronic one, so if anybody wants that, I'm happy to share. I'm sorry I went over. Thank you for the opportunity. I hate to talk and run, but I'll stick around for a little bit if there's any chance to meet folks. Thank you so much for all you do, and thanks for all we're going to be able to do together in the future.